Good evening, everyone. Thank you for joining us again tonight in our continuing webinar series. Um, I'm Jane Beeman from Euclid Systems Corporation, and on behalf of all of our team at Euclid, I want to thank you for taking the time and effort to be with us tonight. We have an a really exciting program tonight on a topic that we found hit the spot with many of our practitioners around the world who will be joining us tonight. We have our wonderful doctor talking about optimizing our Ortho-K success by using topography. I know topography is something that came into my life late into the career, and I'm still learning every day how to make it work the way I believe it should and to give me the data I should. So I'm really looking forward to listening to Dr. Harthen tonight. I do need to tell you, of course, as we do with each webinar, I want to start by telling you that this may not reflect the FDA definition for orthokeratology or even the specifically approved Euclid products and labeling. This is the opinion of a licensed eye care practitioner. Now, I'm very pleased tonight to introduce you to Dr. Jennifer Harthen. Dr. Harthen received her Bachelor of Science degree at Bethel College up in Minnesota, and then got her optometry degree from the Illinois College of Optometry. She then did a fellowship in cornea and contact lenses and immediately joined the faculty there at the completion of her residency. Dr. Harthen also has worked in private practice and hospital-based settings and continues to work in a private practice part-time around her duties at the optometry school. So I want to thank Dr. Harthen. She's had the opportunity to work with me through the years, and I've learned so much from her. And Jen, we are just pleased to have you here and join us tonight. So, Dr. Harthen.
Thank you so much for that kind introduction. It is really such an honor to be with you all this evening. Thank you for taking time out of your busy schedules to spend a few moments with us. I want to thank Euclid in particular for this invitation to present on such a valuable topic to practice in our contact lens practice. And I think that after this evening, I hope you are able to take a few things back to your practice. And what we're going to be discussing over the next 40 or 45 minutes or so is not only how to utilize topography for our initial Ortho-K fitting, but how to utilize topography to optimize our Ortho-K outcomes. And I think it's important to keep in mind that Ortho-K is a process. We have to be patient. And I don't know if you're like myself, that sometimes is hard to do. Not every topography on every single patient is going to be picture perfect. And for many patients, that's going to be okay. Our goal is to be able to understand when we maybe need to edit that picture and when to wait and let that picture come into a bit more focus, as this is going to help set us up for success in managing these patients over time. So some of our objectives for this evening is to really understand the importance of topography and monitoring the long-term treatment and progress for our Ortho-K patients. And I want to spend some time reviewing the different types of corneal maps that we use with topography and what role each of them play in our Ortho-K fitting. And then while the picture perfect typography, well, that's what we're striving for. It's not always necessary and we're not always going to achieve it. But it still is an extremely useful instrument in our Ortho-K treatment process. Ortho-K is so valuable, and I know that many of you are incorporating it already into practice, but when we're looking at topography, it's important to keep in mind, what is our end goal? Are we using Ortho-K for myopia control, or are we simply just using it for myopia correction? What's that patient? What's the goal for them? maybe we have a patient who's a bit older and their prescription isn't changing, they're not progressing. And our goal for them is to provide them with crystal clear, sharp vision. So their treatment zone may need to be a bit larger so they have minimized ghosting and distortion. Whereas a patient who's using Ortho-K for myopia control, maybe we want that treatment zone to be smaller within the pupil so that it induces that peripheral myopic to focus along both the horizontal and vertical meridians. So this then, along with that reduced peripheral hyperopic blur, is going to then lead to that decreased stimulus for eye growth, halting myopic progression. So it's important to keep those in mind as we move forward so that we know what changes we may need to make. All right, so what I'm going to start continuing on with is a question that maybe we might ask, and after some of those results is topography really critical for Ortho-K? And my short answer is yes. A more in-depth answer would be it's important for not only the fitting, but also subsequent follow-up for these patients. Remember that when we apply the Ortho-K lens to the eye, the position of the lens in the open eye environment is not necessarily representative of what's happening when the patient is sleeping with the closed eye. With topography, we're able really to see precisely what's happening with the treatment. Where is the lens position? Is the treatment centered? And the information that we receive from topography is going to help us determine whether or not we need to make any changes. And if we do, what modifications to the lens do we need to make to achieve the desired outcome? So the long answer, there you have it. So some of you may be saying, are you sure that we can't just use keratometry? Well, think of, again, keratometry only measures the central 3 millimeters. So we're missing out then at about 92% of the rest of the corneal surface. The other thing with keratometry is that it assumes that the corneal apex is always centered, and we know that that's not always the case. With topography, we're able to receive so much more information about the patient's cornea, what's going on in the periphery, what are the patient's K values, the amount and type of astigmatism, any irregularities that we may see, asymmetry, eccentricity across the corneal surface. And this is so important when we're monitoring our Ortho-K patients over time. And this is also going to assist us with any troubleshooting that we may need to do. So obtaining an accurate baseline topography sometimes is difficult, but it's critical. And it's critical not only for first lens success, but it's also critical for subsequent visits because the baseline data, that's going to serve as the data for which all follow-up visits are compared to. So we really want to get a good quality scan. That's going to help, determine and tell us information about the size of the treatment zone, the centration of the treatment zone. Is it consistent? What's the degree of the treatment? In addition, baseline data is going to help determine whether or not the patient's a good candidate for orthokeratology. Some instruments utilize fitting software, so it may help us with initial lens selection, initial lens design. So really taking the time to acquire a good quality baseline scan is going to be important. So what can we do? Some patients, they are difficult to obtain a scan on. They're a little bit squirrely. Maybe they don't open their eyes. So it may be helpful to have another person help hold their eyes open. We know that some instruments acquire the image as a reflection off of the tear film. So by instilling a low viscosity artificial tear may help us obtain a better quality scan. Sometimes we see artifacts on our scans and we may falsely interpret that as an abnormality on the cornea when really that is poor tear film. I find it beneficial to take multiple baseline scans and multiple follow-up scans because if I am seeing a change or if I am seeing something unusual, is it just an anomaly or is it really there? I have learned this from one of my mentors. It's always better to measure twice and cut once. So I've taken that with me and it's served me very well. And then also take multiple images if you're seeing missing data, if you see that ring jam, or if you're seeing that interference from eyelids or eyelashes. Most patients are pretty cooperative if you need to take multiple scans. So if we're thinking of just topography, what does an ideal Ortho-K candidate look like? Well, really we want a well-centered map that's not missing any information, and we want that corneal apex to be centered near the geometrical center of the cornea. Now, some patients are going to have a decentered apex, and this doesn't necessarily mean that it's a contraindication for Ortho-K, but it may just pose a challenge in obtaining great centration with that lens. When we're looking at symmetry, we want both the horizontal or the vertical meridian to be symmetrical. And looking at average K readings, 41 to 45 diopters, I think is pretty ideal in terms of the type of patient that we would like to fit. And obviously lower amounts of with the rule astigmatism are going to be more ideal to fit than higher amounts. Higher amounts of astigmatism are going to be very challenging to sphericalize the cornea with Ortho-K in both refraction and in topography. And then we also want to look at eccentricity. Patients with very low eccentricity or high eccentricity, we're going to need to use steeper or flatter alignment curves. So kind of, when we look at an ideal Ortho-K candidate just based on topography alone, these are some of the things that we look at. Now, in terms of looking at the ideal fit, when we place the lens on the eye, the Ortho-K lens should center well. In order for the lens to center well, we want to look at the diameter of the lens. And really, the diameter of the lens should be about 90 to 95% of the HVID. So that's also an important measurement to take. And if we're not receiving or obtaining that information from the topography, again, maybe take another scan or maybe take it manually, but HVID is a really important measurement to take as well, as that's going to assist with centration. When we take a look at the fluorescein pattern of the lens on the eye, we want that bullseye pattern with the pupil centered around that first nice green ring. But really what we want to look at, and is for this specific discussion, is we want to look at topography upon lens removal. And here again, we want to see that classic bullseye pattern where we have an even flattened treatment zone. We have that steepened reverse curve centered within the pupil, and we have a pronounced flattened area 360 representative of that alignment curve. So that's kind of the ideal fit. So we've talked a little bit about the importance of topography and how baseline topography is so important. And it is important because this is going to serve as the foundation for which all future Ortho-K evaluations are based. And topography is also important to help us identify who's an ideal candidate, who may be a challenging patient, maybe who's not the greatest candidate, or maybe who might be contraindicated for Ortho-K. The more time that maybe we invest in looking at these scans, I think the better success that we will have and the better success that our patients will have. So now what I want to do is I just want to spend a little bit of time going over each of the different maps that we have access to and what their role is in Ortho-K. So the axial map is probably one of the most commonly used maps. It's also known as the sagittal map. And really what it does is it describes the power of the cornea. It provides more of a general representation of the corneal contour relative to the optical axis. It assesses, think of it as assessing the optical state of the cornea. And it's good for following progression of refractive change. So that's why we often use it for comparing changes with refractive surgery and Ortho-K. It's helpful to determine the type of astigmatism that a patient has and where it's located. But it also assumes that the center of the radius of that curve is always at the central apex. So it misses small abnormalities, especially in the periphery of the cornea. So if we're looking for true detail, this is not the map to use. But what it is useful for is to distinguish the type of astigmatism that a patient has. So we want to determine, does a patient have regular or irregular astigmatism? So we can see the patient on the left has regular with the rule astigmatism, and the patient on the right has irregular astigmatism. Now, a patient with, mild amounts of irregular astigmatism, it doesn't necessarily mean that the patient is contraindicated for Ortho-K, but it may make them more challenging to achieve an ideal endpoint in terms of vision. So things to keep in mind, and it's important to notice these and talk to your patients about, to tell them you're not an ideal candidate. And some of them may decide to proceed. Others, it may be best to pursue other options. Along with the type of astigmatism, we want to look at the location of astigmatism, as this is going to help us with our lens selection. Is the astigmatism central, or is it spread out across the cornea? Is it more limbus to limbus? Differentiating between the two is going to help determine what type of fit we need. Patients with more central astigmatism are going to do well with a spherical design. Patients who have limbus to limbus astigmatism are going to likely require a toric design. So this is what I use this map for, is to help determine the type of astigmatism, the location, and help determine what type of lens we might need. The tangential map is also known as the instantaneous map, and this map highlights more specific change. This shows more detail than the axial map. This is often referred to as the true curve data. This doesn't make any assumptions about where the center of the cornea is. It's more sensitive, more specific to change. It gives more a detailed representation of where the periphery of the cornea is. And because this map highlights areas of the cornea where sudden changes in corneal shape occur, this is why we use this map so frequently with our Ortho-K patients. In Ortho-K, why this is so important is because we want to distinguish the position of the flattened treatment zone that then transitions to the steeper area under the reverse curve, that red ring. So this is what we use this map for, is to look at that transition, that flattened treatment zone to the steeper under the reverse curve. The elevation map, I think, is one of the most important maps to look at with Ortho-K, and I think sometimes this map is often neglected or is forgotten about. But this map evaluates the height of the cornea in reference to a sphere. It helps determine the height. It helps differentiate elevations, different areas of the cornea. So it's going to help determine how a lens is going to fit. It's going to help assist us with a centration, and it's going to help us determine whether or not maybe we need a toric design based on what we're seeing in those height differences in different parts of the cornea. So I think this is an important map to look at, especially if the patient has a lot of toricity, and looking at those height differences. Do we need a toric design, and how much toricity do we need? This is a nice map to use. Some instruments have this. This is a summary map where we can get all the different maps all together. So we see the axial map on the left and then the tangential elevation. And some instruments also give an image simulation so that the patient can see how they're seeing without correction. And this is an example of a summary map for a patient who was successfully treated with Ortho-K. And again, with that tangential map, you can really see that distinct treatment and that red ring. So this is why it's so important to use that tangential map, because you are able to pick up those changes more distinctly compared to an axial map. Now, different maps are also important to use, and some instruments have this. And this map allows us to take the patient's latest map and compare it to any specified previous map, whether that's baseline or another reference map. And what it's doing is it's displaying the change. It's displaying the change from the map that you took that day to the reference one that you specified. And it's important because this is going to let us see what modifications have been made. Do we need to make any more modifications? This is usually displayed either in the axial map or tangential, but again, I think it's more beneficial. You see more distinct changes with the tangential map. Here is the difference map displayed in an axial, and you can see that it's not distinct of treatment as compared to when it's displayed with tangential display. Now, what happens when things don't always go as we expect them to? Sometimes we have patients who have great vision upon lens removal. Some patients, their topographies are going to be picture perfect, but they're going to have vision complaints. Other patients are going to have zero complaints, but maybe their topographies look something like the ones displayed here. And then we're going to have other patients where maybe their topographies don't look fantastic and their vision is also reduced. So by carefully evaluating what's going on with the topography is going to help us determine, number one, do we need to make any changes? And number two, if we do, what do we need to do to fix it? Now, sometimes what can happen is we can get some artifacts, and some of those artifacts could be due to the patient wearing the lens in the office. Some of you may be recommending that a patient wear a lens on day one for their follow-up, and having that patient then remove and then take a picture may cause what we call, some of us call Ortho-K slip. And that can happen when the lenses are worn in the awake or open eye state and then removed. So we may see some artifacts and some changes to that treatment zone. And that's not really representative of actually what's going on. So again, sometimes it's important to be patient, just reassure yourself and the patient that we need to give it more time. And then in other cases, they may have more visual complaints and we may see significant decentration. So what I want to do now is kind of go over what are some key things to look at about our follow-up with these patients. So centration is so important with Ortho-K. It's one of the most important fitting characteristics to provide effective treatment, to provide great vision for our patients. And no matter what we observe with the lens on the eye, we want to look at this with topography. Topography is really going to tell us the true story of what's going on with that lens being in position while sleeping. The location of that treatment is going to indicate whether a change needs to be made and what type of change needs to be made, if anything. And again, to evaluate the location of the treatment zone, it's best to use the tangential map. What are the concerns if the lens is decentered? Well, if there's just a little bit of decentration, maybe nothing. The patient may be just fine, okay? So a little decentration may cause no issues. And for those patients with myopia control, we want that treatment zone to be centered within the pupil. A little decentration, probably not going to make a big impact. But when the centration of the treatment zone is significantly decentered, then we probably need to make an adjustment. So lenses that decenter can cause various problems. And we can see this on topography, and often patients will tell us that they're having issues. They may present with reduced vision. They may have early regression, meaning that as the day goes on, they may become more myopic before the day ends. They may complain of distorted vision, and that's because we're getting induced irregular astigmatism because of that lens decentration. And for some patients, if the lens is decentered significantly enough and we're using Ortho-K for myopia control, we may not be generating sufficient peripheral defocus. And so that's something really to keep in mind. Again, what's our end goal in our Ortho-K treatment? Other patients, some of you have experienced this where patients are complaining of glare and distortion. And some patients, no matter what you do, they're going to have issues, and it could be because they have larger pupils. Patients who have higher amounts of myopia, they're going to tend to have a smaller treatment zone. Patients with higher amounts of myopia, it may also take them longer to stabilize in their treatment effect. So you could increase the treatment zone diameter, but again, we want to be cautious with that if we're using Ortho-K for myopia control. Some people use Alphagan off-label to help with this, but oftentimes we need to reassure our patients and say, you will usually adapt to this. Sometimes it takes a couple of weeks, but we can assure you that the treatment is working. Let's just give it a little bit more time. So when I'm looking at topography patients and when to make an edit to the picture, the things that I kind of keep in the back of my mind is, what do I see that's going to make me pause and consider editing the lens design? If some of those findings are compromising the ocular health, then I think that an adjustment to the lens is appropriate. If centration is interfering with peripheral defocus, then I think that we need to make a change. If for some reason a patient is just non-adapting to visual distortion, then maybe. And then maybe, Ortho-K for some patients, it may not be an option for them. And also, have we obtained repeatable findings? Are we getting consistent findings on at least a couple of scans? Or was this an anomaly? Have I waited long enough for the treatment to take effect and stabilize? Rarely do I make changes at week 1 or even at 1 month, unless it's something really abnormal that may be causing one of these. I want to give the lens enough time to stabilize, to take effect, and to see what it's doing on the eye in the closed eye state before we make any changes. So some issues that we may see are problems with decentration. Some of the more common ones that we see is a smiley face topography pattern. And this is caused by a flat fitting lens. Now, the flatter the lens, the more superior we're going to see that red ring. And this is caused because the lens usually has insufficient sagittal depth. And this has been caused by we've either underestimated corneal sag or we've overestimated corneal eccentricity. So a patient, when the lens is decentered, they're going to complain of glare and ghosting of images. And what we're going to see at follow-up is less than expected vision correction and an increase in astigmatism. So what we can do to help edit this picture, I hope you guys are catching my theme along the way. I know it's a little cheesy, but trying to make it a little fun. What we can do to edit this is, because it's flat, we need to make it steeper. We need to increase the sagittal depth. So we can do this by, a number of different ways. Some patients may only require one modification. Some patients may require multiple modifications. Some patients may benefit from steepening the alignment curve or steepening the reverse curve, decreasing the edge lift. Some patients, we may need to increase the overall diameter. And if we're seeing, the patient maybe had more astigmatism at baseline, maybe they would have benefited from incorporating toric curves or a toric lens design. Now, the opposite of a smiley face is that frowny face design, or frowny face pattern. And this is caused by a steep fitting lens. Again, the steeper the lens, the more inferior the lens is going to decenter. Now, this one is caused by excessive sagittal height, and this is caused because we've overestimated the corneal sag or underestimated. So if you have a hard time remembering all of them, just remember one, because everything's going to be opposite for the other. What's also important to keep in mind for a frowny face, sometimes this is caused because the lens is too small. So again, we want to think about that HVID and lens diameter, that ratio. Make sure that we have measured an accurate HVID so that we get an appropriate lens diameter to start with. And patients are going to have the same complaints, and we're going to see similar findings. When that lens is decentered, increase in glare and ghosting of images, increase in astigmatism, less than expected myopia reduction. Now, when we're talking about increase in astigmatism, some patients are going to have that even if we have a perfectly centered treatment zone. Some patients are going to maybe have half a diopter, 3/4 of a diopter. When we're getting more induced astigmatism, we probably need to make an adjustment because they will not be able to adapt without some form of vision correction following. So how do we edit this picture? We need to decrease because it's too steep. The sagittal depth is too high. We need to decrease the sagittal depth. So we can flatten the alignment curve, decrease the return zone return curve, increase the diameter, increase the edge lift, and then also incorporate toric curves or a toric design. So again, there are multiple ways, and I would encourage you, if you are just beginning to incorporate Ortho-K into your practice, or if you're still not comfortable troubleshooting these on your own, utilize consultation. They are awesome. Tell them what's going on with the lens. Send them your topography, send them the baseline, send them the follow-up. They have been so instrumental and valuable to our practice here at the college and in private practice. I can't say enough good things about utilizing them, but you learn so much from them as well. So it's a good practice to have, to learn from them and share with them. Lateral decentration, I think, can be one of the most difficult fitting anomalies to correct for. Lateral decentration can occur nasal or temporally, and we can also see, nasal and temporal decentration along with superior and inferior. So a lens could decenter superior nasal or superior temporal, or it could be inferior nasal or inferior temporal. So lateral decentration is difficult, and this is usually because of lens diameter not being the correct ratio to the HVID. So again, that HVID, the ideal lens diameter, is going to be about 92 to 95% of the HVID. So if we're also seeing with lateral decentration superior inferior along with that HVID issue, it could be that we have insufficient or excessive sagittal height. It could be that the patient may have a decentered corneal apex, or maybe their corneal curvature is asymmetric. So again, go back to the baseline. If you're not sure about what's going on in terms of your follow-up, always go back to the baseline and see what's going on there. One thing that I find interesting with these patients is they have more peripheral distortion, and that's with their lateral decentration, compared to patients who have superior or inferior decentration. I find that patients with lateral have a little bit more peripheral distortion. And then again, for editing, you can increase the diameter, incorporate toric curves, and then increase and decrease the sagittal depth. Now, besides decentration issues, we may also see islands. And with islands, we may see a true island or a false island. And we may say, well, what's the difference? Well, a true island, what has happened is between the pre-fit and the post-fit map, we have actually steepened the central part of the cornea. We will see steepening in the center of that treatment zone, but that steeper area is still going to be flatter than baseline. So we've actually changed the corneal shape in that area. So we don't have a uniform central tear thickness under that lens. When we remove the lens, we're not going to see epithelial damage. But what's interesting with this, how we know it's true central island, is not only are we going to see this effect on topography, but the patient's going to have a very unstable over-refraction over the lens. They're going to have an unstable endpoint on refracting. They're going to have reduced best corrected vision. And also their vision is going to typically be worse than their pre-fit vision. And again, that's because of that central distortion. So to help with this, this is because the lens is too steep. Okay, we have excessive sagittal depth. So what we need to do is decrease. We need to reduce the reverse and or alignment curves. But I think even though these patients may not have central staining, I find it beneficial to still review what is their care system. Are they using the proper disinfecting solutions? Are they using an artificial tear in the lens before application? If not, maybe recommend that they do so. And if they are, maybe recommend something different. I like to use preservative-free. That's just my opinion. That's what's worked with my patients. And if they're using a less viscous, maybe switch to a more viscous solution. A false central island is typically caused by a flat fitting lens. And this then will have corneal staining upon lens removal. Here we don't have true steepening in that central portion of the treatment zone. We're going to get a lot of distortion on our Placido-Meyers. So to correct this, we need to increase the sagittal depth. And then here I'll also recommend that the patient use artificial tears if they're not already doing so. So those were some tips and some common findings that we may see, maybe not, on Ortho-K follow-up. And by identifying what's going on with the patient, being able to recognize, do we need to make a change when they're significant enough, I think will help set us up for success. What I want to do now is go over several cases where we've made changes and maybe where we haven't. So the first patient is a 7-year-old presented for an Ortho-K fitting, and she was referred by another office. If you take a look at her manifest refraction, you can see that she's got an ISO. The one eye, absolutely no prescription. The other eye, she has 4 diopters. And what's interesting, in 2 years, she's progressed 2 diopters. Both of her parents are highly myopic. Her mom actually had a retinal detachment and scleral buckle. So both of her parents very well educated about the risks of high myopia and the comorbidity associated with high myopia. And from that, they did a lot of research. They did a lot of research on myopia control, myopia control options, and subsequently, they actually came in asking for Ortho-K. Because the parents were so motivated, the patient was actually right on board. She was like, I can do this. I've done other things that are probably more difficult. So she's like, I've got this. Now, as far as our testing and our workup for consultation, this is just kind of like what we do. We do near testing, topography, obviously, pupil size, HVID. We want to measure axial length. We do axial length at baseline and annually, slit lamp, cycloplegic refraction, then obviously a good health check of the back of the eye as well. And looking at her baseline topographies. Now, could her quality of scans been a little bit better? Maybe. But we do see that she's has about 1.5 diopters of width rule astigmatism on her right eye and about 1.75 diopters on her left eye, but nothing too significant, maybe a little bit asymmetric in terms of the superior and inferior meridians. But overall, she should be a pretty good candidate. As far as all of our follow-up visits, what we were doing is checking her uncorrected vision, doing refraction, taking a look at topography, and doing slit lamp, and then telling her to bring her lenses with her to every visit. Now, another thing to keep in mind is when you are doing your baseline topography and your follow-up visits, make sure that you're using the same instrument for every visit so that you can do that comparison data. If you're using one instrument for baseline and then another instrument for your first follow-up and then another instrument or going back and forth, you're not going to be able to appreciate what's happening with the treatment. So again, use the same instrument for every follow-up. At her 1-day follow-up, her uncorrected vision, again, the right eye, great vision, left eye, she went from a -4 at 1 day to -150. And she's seen 20/70. If we take a look at that tangential map, we can see that it's pretty well centered, but we haven't achieved that full treatment effect. But again, it's only 1 day. So we reviewed application removal. She wasn't having any complaints, no issues. We reviewed disinfection protocol with her, and we told her we're going to see you again in 1 week. At her 1-week follow-up, what's interesting is that her right eye wasn't seen as good as her left eye. Her left eye, she was seeing 20/20 minus, and her refraction was plano. She had absolutely no complaints. She was like, this is easy. I've got this. It's easy. And she actually asked if my right eye starts getting a little bit blurry, can I have a lens for this eye as well? If we take a look at her topography, again, we can see that her treatment is starting to take more effect. We see that center of the treatment zone is becoming flattened. We're seeing more definition of that treatment ring. So we said we were doing well. We reviewed everything. Let's see you back again in a month. So here is her topography again at 1 month. Now, why it's important to, again, look at that tangential map. If we were to look at her axial map, we might say, does she have an island starting? But if we look at that tangential map, maybe, so we recommend that she use some artificial tears, but she had absolutely no corneal staining. But that's why it's important to really take a look at the tangential map, because that's going to tell you the true shape of the cornea. What's happening with the cornea gives us the most detail. At the 1 month follow-up, doing well. She seen 20/20, no complaints, refraction plano, no issues, even though the treatment zone may be slightly decentered temporally. Now, again, here's that question. Do we edit anything? Do we change anything? Sometimes when we strive for such a perfect fit, we may be chasing things, we may make things worse. So while it's not perfectly centered, it's still achieving the desired outcome. So in this case, we leave it alone. Now, what happened to her? Well, she disappeared for 2 years. Okay. Now, with our Ortho-K patients, typically we want to see them, after that 1 month. I like to do 3 months and then 6 months and then every 6 months after. And it's so important to stress how important it is to see them for those regular visits and then annual visits to make sure that the patients are still doing well, that they're compliant, the lenses are still doing what they need to do. And here she is 2 years later. So while they were highly motivated, they came in asking for Ortho-K, they disappeared. And the question is, well, where'd you go? Well, they were traveling abroad. She was in a study abroad program as a 7-year-old. It's amazing. And she was doing well and had no issues, but then she came in and started saying, my vision is distorted. And the parents were concerned, has it stopped working? Is the treatment no longer taking effect? Has she progressed? Well, the lens now is over 2 years old. We know that Ortho-K lenses are made out of a very high decay material. So with high decay materials, they tend to lose shape. They're only effective maximally for about a year. So the lens had warped. So because of that, she's not getting the treatment that she had 2 years prior. So we didn't necessarily need to make changes to her lenses. What we did is we just reordered her same lens. And after she started wearing her lens, she was heading right back in the same direction as she was previously. Again, it's taken a little bit of time, but I think that this just kind of reiterates how important it is to stress compliance, making sure that the patients and their parents, whoever it is that we're fitting with this, are committed, because it is a process. This isn't something that we fit and then bye, see you later. We need to make sure that the patients are committed to follow-up so we can monitor their progress, but also so that we can make sure that the treatment is still working, so that we can make sure that they receive a replacement lens. This is another patient. So she is 12 years old. She was referred by family friends. They have friends who also do Ortho-K. And if you take a look at the topography, the cornea looks pretty spherical. There's a little bit of with the rule astigmatism, only about a 1/2 to 3/4 of a diopter. And manifest refraction, she has a lower amount of myopia with some SIL. So we decided to go ahead and fit her with Ortho-K. They already knew about it, but she came in at her 1 week follow-up, and uncorrected, she was 20/25, but she was miserable. She would not stop complaining about blurry vision. Her vision is distorted. She's like, you got to make this better. You have to fix this. I can't function. Like, you're 12, but okay, let's just give it a little bit more time. And if you take a look at her tangential map, we can see it's only been a week. Okay. The treatment has not fully formed. It has not fully taken effect. So said, let's give it some more time. You're seeing well. You're 20/25. You're almost there. Let's give it a little bit more time. Okay. So like, okay, said, let's see you back again in 3 weeks. Well, the patient came back again in another week. And we're like, why are you here again? She's like, well, my vision is just still so blurry. I can't stand it. I need to make sure everything's okay. I think I need new lenses. I think you need to order me new lenses because I just can't handle it. Well, uncorrected, 20/25 in each eye. But if you notice from her previous scan to this one, you can see how the treatment ring is changing. It started off as darker and now it's a little bit lighter. Do we make a change? What are some additional questions maybe to ask her? Asking her, how many hours of sleep are you getting each night? Are you wearing them every night? Oh, I need to wear them every night. Well, you're just starting, yes. Well, my friend who wears these is only wearing them every other night or every couple nights. So we said, we understand that your friend is doing it this way, but we talked about how you need to do this. You need to get at least 7 to 9 hours of sleep every night. And you need to wear them every single day for at least this first month. And maybe you cannot wear them every single night, but let's go ahead, let's wear them consistently, and we'll see you again in a couple weeks. Well, she came back at her 1 month and she said, they're great, they're awesome, I love it, you're right. And I thought it took a lot for a 12-year-old to, be so vocal and then be very mature and saying that we were right. She had absolutely no complaints of vision distortion, and her uncorrected vision was 20/20. But again, here you notice again that now her treatment ring is more red. So again, that's maybe due to her, instability with initial treatment and then her lack of wearing and her lack of sleeping. But this also stresses the importance of patience on both the patient and on the practitioner, just saying it takes time, it's going to be okay. The next patient is a 13-year-old and he had changed 2 diopters in a year. And he has more of a moderate amount of myopia with more so than we've had in our previous examples. Now, what I also want to highlight with this case is his baseline scans were not great. Not an easy patient to take good quality scans. So you can see we have missing data from his lids. And because of that, it looks like we may have more irregular astigmatism. That's probably due to the lids and from the tear film, but we still went with it. We just discussed all the options and both the patient and the parent decided to proceed with Ortho-K. Just highlighting some of the follow-ups for the patient. So if you take a look at this scan, we can see it's not a pretty picture, not great at all. The patient came in for his 2-week follow-up and he came in wearing his lenses. We're like, why are you wearing your lenses? I don't know. I thought I would. Patient was compliant with sleep schedule, was sleeping on average for about 9 hours per night, had absolutely no complaints, was happy with the vision and the comfort. Vision through the contact lenses was 20/20. Upon lens removal, uncorrected vision was 20/25 minus in 20/20, and manifest was about -50 and -1/4. But those are not great looking scans. Now, part of that could be, is it because the patient presented wearing the lenses, or is it because we need to make a change? So the question is, do we make a change to these? Okay. So we decided to hold off, say, okay, when you come back in for your follow-up, come in not wearing your lenses. Let's see how they look at that 1 month period. And because if you notice too, the lenses are decentering a little bit superiorly, but again, not having complaints. If he's not having complaints, do we need to make a change? So at the 1 month follow-up, the right eye, we notice better centration, but the left eye, something is strange is going on. And he also reported that after he put the lenses on immediately, he had a lot of burning. So when the patients immediately have burning upon application, I think it's solution. The patient said didn't wear the lenses for several days over the last week or so, and uncorrected vision was much worse. It's 2200 and 2150, but putting the lenses on, corrected vision is 20/20. So the question is, do we make a change here? Well, something that happened between week 2 and 1 month. So what happened here? Could we just take this data and make a change? We could, but could then we be creating more problems if maybe we didn't investigate a little bit further? The patient had the lenses switched. Somehow he switched the lenses. So he was wearing the wrong lenses on the wrong eye. And that's why maybe the lenses weren't fitting very well and he was having the worst vision. So what's nice about lenses is that they have their parameters lasered onto the periphery of the lens, so we can easily verify what the patient should be wearing. But if something doesn't make sense, pause and take a step back. And is it really that we have to make a change to the patient's lens? Or is it that we have to review what they're currently doing? Or maybe is it that they have their lenses switched? So after 3 months, the patient came back and still reporting good vision again. No complaints. He said that the vision may be slightly worse at the end of the day. And here we're seeing pretty decent centration with the right eye, but the left eye, you may be noticing that we have superior nasal decentration. So would you make a change here or would we leave it alone? For this one, I would probably make a change because of that decentration, because of the vision slightly worse at the end of the day. I would probably change it. Now the lens, again, we didn't have great quality scans at baseline. So perhaps that's why we're having difficulties achieving good centration. So I would want to double check that HVID and lens ratio, overall diameter ratio, to make sure that that lens is fitting appropriately. But when we have that lens that's riding high, what we would need to do is steepen the alignment curve or maybe the reverse curve. And also, because that patient had a little bit more astigmatism than some of our other patients that we've seen in the past, this patient may also benefit from a toric design, incorporating toric reverse and or alignment curves, or even incorporating a toric peripheral curve. So again, we don't want to necessarily make changes too quickly. We want to see if we're seeing those changes that are consistent over time. And then once we have stabilized, if the patient is having, vision issues, or if it may be interfering with that peripheral defocus, then I think at that time it probably is appropriate to make a change. So our last case that I'm going to review is a 9-year-old that had a family history of high myopia. Prescription has changed by 1.5 diopters in a year. Again, more higher level of myopia. So again, her astigmatism looks slightly irregular. It's not a contraindication. It's probably more likely due to poor tear film. So it's just something to be cautious of when we're monitoring over time. Here is her follow-up at 1 month, and she did report slight ghosting of images. And her parents were very concerned about the fit not being perfect. When we were having a conversation with the students about what was going on with the lens, and you can see in her tangential map how the treatment hasn't fully formed, that ring hasn't fully formed. We were discussing that, and I hope I'm not the only one, but sometimes be careful on how you talk about things in front of the patient or in front of the parents, because they were concerned that things weren't perfect. Her uncorrected vision was 20/30 and 20/25. So the question is, do we make a change? Well, for her, it's 1 month. So sometimes at that 1 month mark, we will make a change. But again, she was on that higher level of myopia. So with patients who have higher amounts of myopia, often it takes a longer time for that treatment to take effect and longer time for that treatment to stabilize. So we said, even though that incomplete treatment, we have an incomplete treatment ring, it is well centered. So let's give it another month and see what happens. So we gave it another month, and the patient vision, uncorrected vision, was 20/20. We can see that the treatment took effect. Very pleased with the results. So again, this patient was a higher myope. We just had to give it more time. So I hope in reviewing some of these cases, it provided you with some comfort in waiting or repeating scans versus jumping to automatically make a change to the lens. So what I want to leave you with this evening is just some clinical pearls. Lenses are going to fit differently on the eye when evaluating them with a slit lamp as compared to while sleeping. And that's why it's so critical to utilize topography to monitor these patients over time. We're not always going to have that picture perfect topography, and that's okay. Some patients, we're not going to achieve that. But when we need to edit them is maybe when we have compromised ocular health. Are we having central staining? Is it interfering with peripheral defocus for our myopia control? Is the patient not able to adapt to that distortion in their vision? And I would encourage you, don't be quick to make changes. Are your findings that you're seeing repeatable? Remember that Ortho-K is a process. Be patient. It's so worth it. I want to thank you so much for your time and attention and spending with us on a Wednesday evening. I had a great time putting this together. I also learned some things with my patients as I was putting this together. And I again want to thank you, Euclid, for inviting me to present this evening.
Thank you so much, Dr. Harthens. It's been such a learning experience. And I'm glad to know your comment about be careful what you say in front of parents. It really hit home for me. I've had parents come walking in carrying notebooks full of every progressive topo they've child's ever had. And if it doesn't look like a textbook perfect, they think something's wrong. So I really thought that was quite on the point because they're not very patient as parents. They want it to happen quickly. And we tend to always want to move this along a little faster. So I've always said Ortho-K will teach you patience. Yeah, it's certainly that way. I've got a lot of wonderful questions here. So let's see if we can cover a few of these. For early on, you were talking about patients and populations specifically, and they ask, are you talking pediatrics or adults? Or what's your opinion on pediatrics or adults? You covered the cases were pediatrics. Do you do any adult?
I didn't do any adults. I focused more on the pediatric population in terms of using Ortho-K more for myopia control. But I think the same is true for adults, waiting and being patient. And for some adults, the picture still is not going to be picture perfect, but for those patients, we're probably going to have a larger treatment zone, and because they're going to not be as accepting of some distortion. So I think, when we're starting off, it's important to identify what patient we're fitting. Are we doing this for myopia correction, where we're just trying to improve their vision? Or are we using this for myopia control? And having that in mind as we're following them over time is going to be important. But yeah, I did focus more on using this for more of the myopia control. But as far as troubleshooting, you would troubleshoot the same way, and you would, you're going to see the same problems with adults that you see with kids. So even though I focus the cases on the kids, you're going to see the same smiley face and frowny face and lateral decentration in adults that you will see with kids.
Yeah, I think the only thing I always caution people, if you are fitting adults or children who are driving cars at night, they will complain more of halo and glare than you'll ever hear of younger children. And you may have to adjust your treatment zone and your optic zone, as you mentioned earlier. So that's really the only change I see when I'm looking at someone who's of driving age. What parameter setting or what scale do you recommend for the topographer? So I'm assuming that's a color scale?
Yeah, I mean, if you could use the absolute scale. I think it also depends on what topographer system you're using. I am not going to, I don't promote any topographers, but here at the school, we use them all. I highlighted in this presentation, Atlas and Medmont, but use what's recommended by your system.
Or the other thing I think is often the scale that comes when you get the system, it's like from 3,800 to
Yes,
like 52.
yes.
You don't need that much. Get
No.
it in. I always go a couple of diopters above whatever keratometry and below. So I know I'm kind of in the range. It gives me a better picture.
Yeah. It depends on
Okay.
how, what types of patients you're fitting. If you're doing more
Yeah.
irregular corneas, you're going to have a wider scale. If you're using
Hmm.
patients for more regular corneas, it's going to be a smaller range.
Yeah. Uh, Someone asked, have you tried Ortho-K on a nystagmus patient?
That's an excellent question, and I have
It
not.
is.
I have not, but I don't see why. I don't know, because if this nystagmus, they're, having it all throughout the day, you would think that they would need it to dampen. I don't know. I haven't. I'd be curious if anybody else has. I've just used
I've
regular corneal GPs for wear during the day.
mhm. I've actually seen a patient who had a bit of nystagmus and was doing quite well with Ortho-K, but I don't have any background on that patient. It was
Yeah.
somebody I was seeing for follow-up. Yeah,
Curious to hear more if anybody has.
yeah, it's an interesting question. Is there an area of cutoff at which point you recommend using some kind of a toric elevation design?
I usually do with 1.5.
Mm-hmm. Mm-hmm.
That's my preference. But again, if
Yep.
you're unsure, utilize consultation. They will
Yep.
assist with that. Part of it also depends too on, what are the patient's Ks? Are there any, what's the symmetry? Is, the astigmatism that you're seeing very asymmetric in that meridian? So there are other components just to the amount.
Yeah, I always try to remind myself and other practitioners, if we're talking refractive astigmatism, that's not what these lenses are doing. So it's not like a soft toric where you're correcting refractive astigmatism. The only astigmatism that we can manage is the elevation differences that come in corneal astigmatism. So can the lenses do more than a 1 or 1.5? Absolutely. We can make toric posterior surfaces that'll will really help with corneal astigmatism. So absolutely, just follow back up with the consultation group. That's great. Okay, is there a benefit if the eye image is showing behind the topo maps? Some of them you get the real eye back there.
Yeah, I think so, especially when acquiring, you can see that. But I think so for some, yes, absolutely. You can see what's going on. You can see if you're getting any ring jam. I absolutely think so.
Yeah. Would you recommend any sort of a washout, like a night or two before you make a change?
Well, I think it depends on how significant the change that you may need to make. I had a patient who has been kind of a nightmare, and some of your consultants have been very kind in helping me with. She is the kindest and the sweetest, but is also kind of a nightmare in that um, for a couple nights in a row, she put 2 lenses on one eye. So she had, double treatment. And then how she removes her lens, she actually peels them from her eye. So she had significant issues. So for her, we actually had to do, more than a couple of days of washout before we started over again. And then once we started over, she had lots of decentration. And so then we had to do more washout. So yeah, sometimes when you have to make significant changes or something's not making sense, it is beneficial to do a washout. Some patients don't like doing that. But it's important to communicate with them. And I like to show them the pictures and tell them this is why we're doing what we're doing. You have to be careful with that because, again, if it's not completely perfect, they get a little bit upset about that too.
Yeah.
But
Yeah,
yes,
and I think you're exactly the right word would be significant. If
yes.
you're just making some of the changes that Dr. Harthan went through with us, then don't take a kid out and go back to baseline and start over again. Go ahead and make those changes with from one lens to the other, a little high, a little low, decentration. But if it's significant, then we're going to have to take them out and go back to square one. Um, Okay, someone asked about the right lens, left lens, but you mentioned some lens designs have the parameters etched into the lens, and some designs have a unique identifier number
Yep.
etched into the lens.
Yep.
So you can match that against the invoice, or you can call the company you got it from, and they can always tell you. I always recommend, I think Dr. Harthen does too, if at all possible, I try to give them different colors lenses. You know, these are not lenses that are going to be seen by anybody except their family at night. So I always try to color code them and make it easier. But if they're all the same color, say you're using a material that only comes in one color, there is some kind of an identifier etched onto the lens, or you're using the wrong company. I don't know what to tell you, because you got to be able to identify what they are. And you cannot check them on a lensometer or a radioscope or something like that.
No.
Okay, Dr. Arthen, if you can make a change after the 1 month or 3 month follow-ups, do you start over with the day one? So if you make a change, do you have them back the next day?
Usually not. You know, if it's a significant change, maybe, but usually not. Usually I will see them back again in a week. That's just my general way of doing things. Part of it also is it depends on, you know, when I'm seeing the patient. If I'm seeing them, you know, and especially right now too, it's really hard for a lot of our patients to get in with everything going on. Some of them aren't comfortable coming in so frequently, but usually I don't have them come in for that one day unless it's a really significant change where I want to see what's happening because they had maybe corneal compromise initially. So I want to make sure that they're not having corneal compromise with that lens, a new lens that we've received. But if it's just a small change to assist with centration, then usually I'll see them back after a week or so. But that's just my way of doing things.
I've got a couple more questions I'm going to cover. You guys asked so many great questions.
They're really good. Thanks for the participation.
Yeah, wonderful. And what we'll do is we'll give you some numbers, and there will be a video available of this presentation. It'll be on our we'll give you information, but it'll be anybody who's attending tonight. We'll send you an email to let you know how to find this in a couple of days. Let me hit a couple of other ones. Any tips for just increasing patient comfort in those first few nights?
Tell them it'll be okay.
Tell them to close their eyes.
That's
what I always tell them. Close your eyes. It's blink that they feel, I think.
Yeah, I think what's interesting with a lot of, I'm just talking now, well, kids, well, even adults, right? You know, many kids and adults, when they're going to sleep, they just don't go to sleep. They're on their phone, right? Or they're doing something else. They're not closing their eyes. So telling them that these lenses are meant to be worn while you're sleeping. If you have your eyes open, they're not going to feel great. So in order for them to feel the best, in order for you to adapt quickly, you really shouldn't be doing anything. Put the lenses on and go right to bed. Put your phone away, as hard as that is. You don't need to be texting anybody at 9 o'clock at night. If you're 12 years old, put the phone away. You don't need to be watching anything. But I think just kind of telling them, do this for a good couple of weeks, and then it's going to feel so much better. But also using artificial tears. I use artificial tears a lot just to help with comfort. And I do that right away. Some people wait until later on if a patient is having comfort issues, but I think that also helps in the initial adaptation period.
You know, that brings me to something that I've learned through my 20 years of fitting these kind of products, Dr. Harthen, is don't forget you are dealing with children. We usually start at very early childhood, but they're going to go through puberty. And I have to tell you, I am amazed what puberty and those hormonal changes will do to a tear chemistry. They will take someone who's been successful and turn them into a raging dry eye almost overnight. So artificial tears, I agree. I just start them out early. I use them a lot. And I think it'll get them through that, but especially if they're in that 13 to 16-year-old range, I think it's really important. I'm going to grab a couple more. I wanted to questions. I wanted to tell everybody that up on the screen is email contacts for our U.S. sales group, and also you can reach out to our Chinese subsidiary, or certainly any of our distributors around the world. So we have information up there. So if you're not familiar with Euclid, if you need more information, if you've got questions for us, please reach out to the sales group in front of you. Okay, I've got, is Ortho-K work for only progressive, or can we use it for late onset, which I consider more kind of that later teenager, adult kind of thing? Yeah.
Yeah, it works for everybody. I mean, we have patients of all ages. A lot of our staff are wearing them, especially
Mm.
now with wearing masks all day and working at the computers. It's increasing the amount of dryness that patients have. So by eliminating their need for contact lenses during the day and wearing glasses during the day, they have much better comfort throughout the day. So we've actually been fitting a lot of our staff with Ortho-K, and they've been doing really well. So I think it can work for anyone as long as you set realistic expectations. Taking a look at their baseline topography, looking at their refractive data, understanding the patient that you're working with, really setting realistic expectations. I think that most patients who fall into the FDA approval can do quite well.
Yeah, there's an interesting paper. It was done by, it was talking about using orthokeratology as a treatment process for acute dry eye patients. It was done a couple of years ago, and I'll think of the doctor's name in just a minute, or maybe Laura can pop it up for me. But anyway, it was quite interesting because these were people who were getting ready to drop out of contact lens wear because of their continuing dry eye problems. And he was able to refit all of them into shorter wear time, GP nighttime lenses, and basically keep many of them in contact lens wear. So I thought that's quite an interesting study. Let's look here. Dr. Six says she's putting up something. It must be a reference, so I'll leave it up there. One quick question about, someone asked, do you have the kids wear their lenses in on day one?
So there's a lot of debate about this. I usually don't. And the reason why is because I like to see them at different times of the day. And a lot of our kids with school and scheduling may not always be able to get in first thing in the morning. So I used to have them wear them in, but I've switched to not. So I know that probably differs from other people, but I've switched to not, but I have them bring their lenses with to every single visit because I want to see what the lens looks like. But for me, it's not so much it's critical what the lens looks like on the eye day one. I really want to see what the health of the cornea looks like and what that topography treatment looks like.
Mm-hmm. Okay, this is a US question, but I want to ask it because I think it's important. We had someone ask about how we go about writing an Ortho-K prescription because we are now required by the FTC to give them that. So, Dr. Harthen, what do you put on the prescription?
That's a good question. I haven't had to do that yet.
Uh-oh, she hadn't thought about it yet.
But
Okay, let me give you what I've done in the past.
But I have thought
Okay.
about it. And we've done it in the past.
Okay, go ahead then.
I
Yes.
put the parameters on there. I do it. I put everything, but I also, and since, Dr. Six is on there and just posted something and she's one of my colleagues, she knows how I am with documentation and I, check other people's, charts as well with my position here. I make sure everything is documented. And part of that is because let's say that I'm not the person seeing the patient for follow-up and there's an issue. We want to make sure that we have the correct lenses. There's so many reasons for having complete documentation, but I make sure that everything is documented. Also, let's say for some reason that the patient were to have an issue. Let's say that the patient were to have a major a complication, such as a corneal ulcer. I would want to know that. And I would want to know, is this because they were not using the lens appropriately? Is there something wrong with their lens? I want to inspect their lens. So I like to be detailed and I like to monitor. So I write down everything.
Yeah, I would say write down everything and write, if you have the label, like many of us scan into records, I would actually, provide a copy of that, but at least write down the name of the company that you got it from. So don't just put GP Ortho-K lens, because they are very different. And so you have to write, I used to write the phone number down there too. So if the next doctor needed to call, they could. We are running way over, and I appreciate all of you hanging on. I got one final question, and then we're gonna wrap this up. But I think this was crazy important because it happens all the time. So, Dr. Harthen, what's the protocol when you acquire a patient from a different practice who's been wearing Ortho-K for a few years, and now they're having issues with their current lenses? Do you wash them out and start over, or do you try to adjust their current lenses?
That's an excellent question. So, one thing that I would ask is, how old are the current lenses? Um, you could try to request the records from the previous. You could talk to the lab and see if they could help you. But if it's, been a period and they're having issues, sometimes I will do a washout. So it really is patient dependent. But that's an excellent, excellent question. But I really do it case by case.
Well,
And
I want to thank
I will
all of
say
you.
too, I will say
Yeah,
too,
go ahead.
sometimes patients sometimes don't know where they were before previously, or they won't provide you with that information. So sometimes you do have to start over.
Yeah, yeah. Sometimes patients are nervous about that.
Right.
I gotta close this out. I will, Dr. Harthen and I will try to go through and make sure we type in answers to all the questions we might not have been able to get to. So if you go back and look at the videotape, or if you contact us, we'll make sure we try to get any questions that we've missed. I want to again thank everybody for attending tonight. And we also want to thank Dr. Harthen for all of her knowledge. All right. Thank you, everyone, for the evening. And please join us. We're going to be doing another webinar early in December. We haven't got the date yet, but please look for emails from us. We try really hard to make these topic areas and content that you can use the next day in your practice. So thank you again for joining us tonight. Thank you again, Dr. Harthen.
Thank you. Thanks for your participation. It was a great discussion.